what's new in OBGYN? There has been recently new guidelines by WHO on abortion called as abortion care guidelines. They have been recently given in 2022 itself. So you have to know what are the important points mentioned and what are the new changes in these abortion care guidelines. So first let's discuss the general changes and then we'll discuss the methods of abortion which have been mentioned there. So I will discuss only the important points which are important, which can come as a question for you. So what about, first thing is in this guideline about the RH isoimmunization. So in the first thing which has been mentioned is about RH isoimmunization, and this guideline says that at less than 12 weeks, whether it is a medical abortion or it is a surgical abortion, you do not need to use anti-D. So this is new thing that in less than 12 weeks you do not need anti-D, whether it is medical or a surgical abortion. And after 12 weeks, in everyone you use anti-D. Next, all the surgical abortions, everyone, no matter what the gestation is, you have to give one shot of preoperative or perioperative antibiotics. In everyone you have to give, right? Similarly, for medical abortion, at whatever gestation you are doing, you do not need to give the antibiotics. Next is the pain management. Now this has been a new change. It has mentioned that for surgical abortion, for everyone, be it less than 12 weeks or more than 12 weeks, the first method for a good pain relief is paracervical block. You can also use sedation and other painkillers, but the first choice in surgical abortion is paracervical block. And in case of medical abortion, you have to use NSAIDs. I've seen at many places practitioners not giving NSAIDs, thinking that it will affect the efficacy of the drugs. It is not so. In every case of medical abortion, you can give NSAIDs, especially ibuprofen, as a pain relief. So this is a new change in this guideline. Next comes to the method. So first we'll discuss the medical methods. So medical methods in the abortion, though they are not major changes, wherever the changes are there, I'll tell you, but important points which you have to mention, what's there in abortion care guidelines of WHO booklet is that medical abortion at less than 12 weeks, we have three methods. One is give mifepristone 200 mg and after 24 hours give misoprostol 800 mcg. This could be either vaginal or sublingual or buccal. By any route you can give 800 mcg single dose. Right? So this is one of the method. Another method is misoprost alone. Misoprost alone can be used at less than 12 weeks, but it is not efficacious as the combination. Third method, which is new in this guideline, is letrozole plus misoprost. Very, very important. This has been introduced in this booklet that letrozole plus misoprost can be used for medical abortion. The dose is letrozole is given 10 milligrams for 3 days daily, and on the 4th day you will give single dose of misoprost 800 microgram, again sublingual, vaginal or buccal. Okay, so let's see the medical abortion. We have discussed at less than 12 weeks three methods, either mifepristone and misoprost, or misoprost alone, or new method letrozole plus misoprost. Okay, next, in more than 12 weeks the same mifi and miso combination is preferred, but the dose is changed. Mifepristone 200 mg is given, then you will wait for 24 hours and you will give misoprost 400 mcg every 3 hours. Again, either sublingual, buccal or vaginal, by any route. Important is the maximum dose is now not mentioned in this booklet. They have not mentioned what maximum dose is. They have just said that you have to be cautious for overt uterine contractions and rupture, which is a rare complication. So maximum dose is not mentioned, but in the hospital you have to take this medical abortion, 200 mg mifi followed by miso. One thing which has been mentioned, that this difference has to be 24 hours. You can give miso only 24 hours after mifepristone. This has been mentioned there. One important thing which is mentioned, who all can undertake the abortions. So at less than 12 weeks, here there could be self-abortion. So patient can use this kit and get used it for herself. It could be ANMs. It could be pharmacists. It could be pharma workers. Then it could be general medical practitioner and special practitioner. Here, after 12 weeks, it has to be a medical personnel. It cannot be a pharmacist and patient herself. It has to be either a nurse or a general medical practitioner or a clinic or a special medical practitioner, right? Yes. If we talk about surgical abortion, it has been clearly mentioned that in less than 12 weeks. So first of all, let's see the cervical priming. So cervical priming has to be done in surgical abortion. The method for cervical priming, if the patient is less than 12 weeks, is mifepristone or misoprost. Anything you can use. If you are using mifepristone, the procedure is done after 24 to 48 hours. But if you are using misoprost, the procedure can be safely done after 1 to 2 hours, depending on the route. If the route is sublingual, you can do the procedure after 1 to 2 hours. But if the route has been sublingual or if the route has been buccal or vaginal, you have to wait for 3 to 4 hours. So this is the cervical priming at less than 12 weeks. At more than 12 weeks, you can use either medicine or you can use osmotic dilators also. Or you can use combination also. Right? So I'll repeat. At less than 12 weeks for cervical priming, use Mifi, wait for 1 to 2 days, or use Meso and wait for 1 to 4 hours, whatever the route you are using. You can also use osmotic dilators, but that has to be used only after first trimester, and you can also use the combination after first trimester for cervical priming. The method, so it has been clearly mentioned in WHO that at less than 12 weeks, the first method is vacuum aspiration. It can be electric vacuum aspiration, it can be manual vacuum aspiration, but it has to be a vacuum aspiration. Okay. After 14 weeks, it is dilatation and evacuation. So this is the next method which is used after first trimester, dilation and evacuation. Again, vacuum aspiration, they have said, could be done by nurse and could be done by again, general medical practitioner, clinical advisor and specialist medical practitioner. But dilation and evacuation need expertise. It can be done only by general medical practitioner, and special medical practitioner means the obstetrician and gynecologist. So this is the new changes, new important things which have been mentioned in WHO care guideline. Important another thing which you have to discuss is the contraception, which creates a lot of confusion. So after abortion, remember one thing. After abortion, you can immediately use any method, be it CHCs, be it IUCDs, any method or any other method can be safely used immediately after abortion. Unless it was a septic abortion, IUCD can be safely inserted and CHCs can be safely given. So this was all about abortion. If I revise only the important points, then the important point about new WHO care guideline is that RHS immunization is not given at less than 12 weeks. All surgical abortions need to give antibiotics. For medical abortion, no antibiotics. Pain management, either use paracervical block in surgical, in medical NSAIDs. The methods which are important are at less than 12 weeks, we have 3 choices: Mifi plus Meso, Misoprost alone, and combination of a new drug, letrozole plus Misoprost. And in case of after 12 weeks, the mifepristone and misoprost again can be used. In case of surgical abortion, the cervical priming is to be done using mifepristone or misoprost or osmotic dilators after first trimester. And the method at less than 14 weeks is vacuum aspiration, and after 14 weeks is dilatation and evacuation. I hope it was clear. Thank you.